I think in today's society, it's really important to look and to understand about male and female typical characteristics. Remember, just because you're male doesn't mean you don't have feminine characteristics based upon literature and vice versa. And I think the most important thing that I think should resonate through the presentation is that it's about our patient who's in front of us, and we need to ask them. Too many times we put our own thoughts, we have our own aesthetic culture that will, we read about things like, for example, the ideal facial shape. You say it was a heart shape. Well, who says that? And why is that most ideal? So just remember, we do have a culture in aesthetics, and we want to be careful not to push that on our patients. And we always want to see who they are. There's so many different terminology from when I was young, with people who are fluid, people who are pansexual. Abrosexual is the newest one I just heard about. It's orientation that shifts frequently. For example, asexual to bisexual, omnisexual, transgender. And Tracy and I were just speaking before. She had a wonderful presentation on a surgeon who works, who does transgender work, just so you know, Trace, I don't know if you this, one of my things I've always wanted to do is work closely with somebody, a surgeon who does this, because I think with our background with injectables, both neurotoxin and dermal fillers, we can make a huge difference to support the efforts of the surgeon. And I'm sure that's why the surgeon wants to do this, which makes me very happy because they're looking at it from multi facets, which makes me happy. So we're just going to talk about basically male female characteristics. Um, if Kevin's gets his computer to advance, how's that? So the big word is sexual dimorphism, but if you say this to most people, they'll have no idea what you're talking about. I was doing a anatomy course, and one of the physicians was there, and I was talking about sexual dimorphism, and he kind of stared at me. He's like, "What's that?" And I told him. He starts laughing because he knows I come up with these terms. He thinks I make them up. I said, I'm not making it up. But if you do read in the literature, at least you understand what it means. But we're really looking at male versus female features. And in general, masculine features are usually stronger, larger, more angles, flatter contours, and feminine faces are softer with transitions. Um, I think you see sometimes more refraction of light off of certain areas that we'll speak about. And we really need to recognize these differences and understand to really best treat our patients. And that's what this is about. Especially say if someone's transitioning to male or female, or vice versa, it's so important to understand these minor differences. At the end, I have a picture of someone who you may know, and we'll talk about what you guys are seeing. I'm going to have you get a little bit involved, if that's okay. And it just will make it a little bit more interesting. So the artificial assessment means noticing differences. And if you ever notice, some of us may be injecting now, maybe you're new to injectables. And if you're new to injectables and the aesthetic medical side of things, this is an amazing concept to learn when you first start, because many injectors may not be aware of this or they hear one part of it. So I'm very happy you're here. And I think those who've been with us for a while, if there's any stories, like I said, you can share to help all of us, I would appreciate it. So we're going to start what we call cephalocaudal or superior to inferior. So we stop top of the head down to the toes, but we can stop at the neck actually. How's that? So I'm going to first talk. I have a question, Tracy, since you're there. Can you see my pointer?
Yep, I can see
All
it.
right, good. That makes me happy. And you're going to tell me if I go offline for any reason. So we're going to do male versus female. The male forehead, a shape, is a little bit more rectangular. If I drew lines, come over to the female, I call it a D shaped. It comes up, it's more arched at the top and then comes down. So that's why I call it a D shape, because it makes like a D laying on its back. The other thing about a forehead, which is quite interesting, it's hard to see here because of the refraction of light, but a male forehead typically would be convexed, concaved, and then convex because there's a heavy brow ridge. For females, it's convexed. Looking at the eyebrows going down, men, eyebrows are typically a further distance, thicker, and lower set without arching. Females are not quite as narrow. She plucks a bit, but they're a little bit more narrow. And typically there's more of a shape to it. Now, this is the shape that people are celebrating at this time, right? In certain cultures. Caucasian culture, yes, but not all. There's some Asian cultures who wouldn't find this overly beautiful with that lateral brow there raised. So remember, brow shape is really a cultural thing and also a fad, if you will. It'll come and go, and the thickness of eyebrows. I say that because when I was younger in the 70s during the disco era, my sisters would all pluck their eyebrows. Then as they got a little older, Brooke Shields, which is an, you may not even be aware of Brooke Shields because you may only be in your 20s, but Brooke Shields developed, she's the one who brought into trends bushy brows. So a lot of the women couldn't grow their brows back, but bushy brows. And now brows are a nice thing where they like to see some fullness to them. But the shape has also changed through the years. So I just want to bring that up. That's part of our, when I talk about our cultural biases that we can bring to the table. So I wanted to talk about the eyebrows. Going down to the eyes themselves, men have smaller eyes. Women typically have larger eyes. The interesting thing here, skeletal wise, if we kind of penetrate through the skin and all the tissue layers, male orbits of the eye are actually larger than females. And of course, as we age, that actually the orbits get larger and grow more in an oblique way. But that's something always interesting to know because we really have to see what's happening underneath because what's happening underneath is telling us what we see. And you'll hear different terms when you look at someone's face. You'll say what I visually see, what I see topographically, sometimes what I see phenotypically. So you'll hear different words used. It just means what you're seeing on the outside in the skin. Going down to, I can say glabella, but remember the muscle, we're going to get to muscle. Muscle mass is stronger in men. The nose. Males' noses are typically wider, and the distance between this ala and the lateral aspect of this ala is called the bialar distance. So a bialar distance of a male is typically larger or wider, excuse me, than that of a female. The other thing about a female that we're going to see in the next slide, they have something typically, it's more feminine called a nasal tip break. It happens right here. So the nose lifts up a bit, like a little bit of a ski jump. Going down further to the cheeks. This is a very important ratio that people speak about quite frequently. It's called the bizygomatic width compared to the bigonial width. So the bizygomatic width is the furthest projection of the zygoma, the bone here and here, as compared to where the mandible comes down with the angle, where you have the ramus here. So this is called the bigonial width. So in males, if you draw a line straight down, it's in the alignment with is more male presentation or slightly more narrow, meaning the bizygomatic width may be slightly more narrow, but it's at least a little bit narrow or in alignment with the bigonial width. For females, you'll see that the bizygomatic width is greater than the bigonial. She has this patient model here, if you will, has larger masseter muscles. We can see that, you know. But even with that being said, if I draw a line straight down, you'll see that the bizygomatic width is greater than bigonial. The other interesting thing about a cheek, a male cheek is a little bit more centralized, which is the malar eminence, the area that sticks out the most anterior that people stare at, and there's a subtle drop off. For females, look how it shifts lateral. Do you see that? Right there. That's a huge difference. I've seen people inject cheeks, they do it all the same, and they feminize men because they increase this bigonial width and they give them more of a lateral aspect here. Maybe the male wants it, and that's okay, but in these cases, I don't think they did. The nares is usually wider also. That's why I had that there. The lips for men are typically a little thinner. And as you go down to the chin, we're going to talk about a couple of things. First, we're going to talk about the width of the chin. If you take the oral commissure where the upper and lower lip come together, that's all that means, and draw a line straight down and straight down here, that should be within the width of the chin. That's what we use as a guideline. For females, we use something called the inner canthus, which is the inner part of the eye. If you draw your line straight down and draw your line straight down. So you can see the chin is more feminine. It fits within that ratio. Now, there is some literature that talks about a width of the chin. They do the bialar distance or width. So if you look at that, it's a little bit less than the oral commissure. But there is some literature that they do reference the width of the chin this way, but most of us now accept the oral commissure width. The other thing is the shape. A woman's shape of her chin is typically a little bit more rounded. Men typically come down and it's a little bit more squared off. So if I was a male and I came in and I said, you know what, my chin it feels weak. I wanted to look stronger. And I asked him, stronger, do you mean, show me a picture a little bit more masculine? Is that what you're speaking about? And they'll say, yes, that's what I mean, stronger. Okay, great. Because, stronger means different things. We have to discuss what that means, right? Don't always assume you know. So that would be something where what I would do with their chin. I may have to build it out a bit, maybe, but may have to widen it. And I may have to try to flatten the bottom if I can anatomically, right? So we're reshaping an area. Coming down to the mandible, we're going to look at the next slide. It's a little bit, to me, it's a little bit clearer because it's a side view, but our bone is thicker. That's most important to remember right here. Muscle mass, obviously, men have greater muscle mass. As we age, this comes into play a lot because our muscle mass and bone is greater, the density of the bone. So, for instance, a female as they age, you guys will start seeing, I call them wisdom lines, but people call them smoker lines. But dealing with a mature population, I don't use smoker lines, I use wisdom lines because many times they never smoked. But yes, there's mechanical manipulation that happens from drinking out of straws, things like that over time. But you'll notice that the females will get what we call perioral or irides or wrinkles around the mouth. And it's because they lose the underlying structure quicker than the men, because ours is thicker. And being such that muscle around the mouth contracts, creating those lines. With men, you won't see this till later. Now, my patients look at me, they're like, well, you can grow hair. I said, yeah, but if I take my hair away, you won't see my lines yet. You'll see it later in life. So it does play a role also in the aging process. Skin. Typically, our skin, remember, also we have estrogen, testosterone hormones, but men's skin is typically thicker. We produce more sebum. We also have greater vasculature, right? This is the side view that I was talking about, the nasal tip break. And as you can see, it's right here. It sits up a little higher. That's a nasal tip break. The other thing is this nose comes up, it creates an angle under here. This is called the nasolabial angle. For females, this is greater than males. For male, we say it's less than 95. For a female, it's greater than 95. So if you were going to feminize somebody going through transition from male to female, we may want to maybe inject a little neurotoxin in a muscle that pulls that down. It could help. Some people will do filler to help push it up. There's different things you can do. And once again, there's different risk factors. I'm not telling you to do this, okay? There's some different risk factors. But I just want to say these are things we can do to make it more feminine looking. The Rydell's plane. Basically, if you took a cotton tip applicator or a stick and you dropped it from the tip of the nose down to the chin, that is what it is. It helps us with the amount of chin retrusion. Is that chin in the place where does the chin sit too far back? Is it too far projected forward? This helps us with that plane. But there's something interesting because for females, when you go down, the lower lip sits about 1 to 2 millimeters behind, where a male, both the upper and lower lip would touch this line. It's a very weak measurement, I have to be honest personally, because it's very hard to measure this, but I want to mention it in case you do see it. The width of the mouth I put in here purposely, and I do this not because it has to do with male, female, but because it's a ratio we forget. And I like to bring it up, or maybe you never learned. The width of the mouth, there's two different ways to look at it, and there's two different perspectives on this. One, and I go by this one, the limbus of the eye is the color, and where it meets the white, this is the medial limbus, and this is the lateral limbus. If you draw a line straight down and draw a line straight down, that's about what we think from a ratio and proportion would be a good ratio and proportion for the width of the mouth. There are other people who will use also mid-pupillary line. So you take the pupil and draw it down and take the pupil and draw it down. So either one of these is probably acceptable. I have a tendency to go for the other one, which is medial limits, but it doesn't matter. The importance of this, I like to just bring this up when you guys are doing your lip filler, because if somebody has a wider mouth, you're going to change the way you inject it so you don't augment or enhance the width more. That's the only reason I bring that up because it's something I see in injections clay. People don't look at that ratio and it creates an odd look for many people. Going down further, the gonial angle. For male, it's 100 to 120, closer to 90 degrees. For females, it's greater than 120. So I'm going to show you, it's the angle that goes from the ramus down this way. All right. As we age, remember this angle also gets more, gets greater, um, just so you know, as we age. So that's also something important because as we age, some of these, understanding how people age is very important. And also this part of what we're talking about, male-female characteristics. Okay. So I'm going to stop there for 1 second, if I could. And I'm going to look at these two pictures, but it's hard for me because I can't see people, and I'm sure there's a way I can do this, and I always screw it up. But let's walk through this male-female. It's the same person as we well know. Bruce Jenner, of course, is his prior self. That's when I was a kid. And of course, he transitioned into female. So I want you, let's walk through those concepts. And I want you to, as we go through, if you have a piece of paper and a pen, what I'd like you to do is write it down, what your thoughts are as I walk through. So I'm going to give you a little minute after each time I speak to help you get these concepts down. So it's harder to see his forehead, isn't it? Because of his hair. Beautiful hair, very typical of that time period. I could never have this hair because I had very kinky curly hair, so I used to get jealous of this. I used to feather it. Anyway, shape of the forehead. A male forehead, do you remember the shape of a male forehead? I want you to write it down, the shape, and the shape of the female forehead. Take a moment, just write down if you remember what the shape is. And then what, as far as concavities, convexities, a male's forehead, at the top, is it convex or concave? Write down which one you think it is. And then the opposite occurs, right? And then heavy brow ridge. So I'll go over convex, concave, and heavy brow ridge. For a female, is it convexed, concaved, both? Look at it more as convexed. Perfect. Looking at eyebrows. What do you remember about the eyebrows? For a male, do they sit higher or lower? And for a female, do they sit higher or lower, and do they have more of an arch? He had a really nice arch to his brow here, actually. But I want you to look what they did. Do you see this? Took the forehead. I don't know the shape, but he had a little bit, you can't see, there's a little bit of a concavity right here. Do you see how the forehead now is convexed? The eyebrows have been lifted, brow lift, and a little bit more of the lateral aspect to give more of a shape to it. More skin between the underlying the brow and where the lid crease hits of the eye. All right, kind of interesting, isn't it? Still widespread, but once again, it's fine. The eye shape. Remember, we said females have larger eyes typically. The problem is with this, you only have so much you can work with. So it looks to me, and Tracy, you can also, I think what they did a little bit of maybe a lateral canthoplasty. They changed the shape slightly, making it more of an almond shape, more so than here. So they look a little smaller to me. So I think there was some surgical alteration. Looking at the cheek, bizygomatic width, bigonial width. If I draw a line straight down, it's probably right about the same and right about the same. If I just go straight down, here, here's a bizygomatic width and bigonial. This angle's a little odd here. It's almost in direct line, but a little bit projected. This seems a little bit more projected over here, but there's a slight tilt to the head looking over to the right-hand side. So it's harder to look, but they increase the bizygomatic width. Look at the malar eminence right here. See, it's a little bit more medial with that subtle drop off. Look what they did. They took it and they went lateral with it. Do you see that? Especially here, you really see it, right? So they just shifted it a little over this way, which makes it more feminine. The nose, he had a nasal tip break to start with. See that? His nasolabial angle is greater and more feminine. So like I said, a male can be very attractive, but have both features. And the bialar distance is pretty wide. But you see, even with all that being said, it's interesting. They still slimmed out the nose. You can see the difference in the ala, decreased to me, it looks like an increased alar distance, but I think it's smaller. And they kind of changed the shape of the nose. Now, to me, they took a lot of the tip out, was more masculine as far as the tip of the nose. But to me, they ablate a little bit of the nasal tip break, but maybe they didn't if I see him from the side. Oh, she's, what is that? There we go. Now, lips, they try to make them a little fuller and coming down to the chin. All right. We said for a male, oral commissure straight down, oral commissure straight down. His chin is typically a little narrow. It's a little flattened here. See that? But it is a little narrow. Now look at here. We said inner canthus. We go straight down. Now there's some fat and the angle's a little odd and come straight down. A little narrow. But to me, and they see how they try to round out this chin a bit? Yeah. Come down further. What do you notice here? Some extra cartilage, don't you? Yes, very masculine. You can see they shaved it down. His masseters, look how thick his masseters are. They're incredible. The masseter is a muscle we use for chewing. It's one of the muscles of what we call mastication or chewing. They're so large. Here, I don't know if they did so, they probably debulked it, it's called, more than likely. And they may have used neurotoxin to decrease it. We can use neurotoxin, as you well know, or maybe you don't know, to decrease the size of the muscle because basically we're telling the muscle, hey, you can't go to the gym anymore, right? You can't build up anymore. So we can shrink it down. And I see two chats. I gotta look at my chat because I'm really bad at this. Absolutely, Lisa Clever. Aw, thanks, Trace. You're the best. I'm like looking, trying to figure this out. Now, where's my so I'm going to, that was, as far as going through, I'm going to kind of end that here. I'm going to stop sharing because that was really the presentation. Definitely surgical left to change the angle. Yep. Thank you, Trace. I knew you were going to be right there with me. Perfect. So now I can hopefully see people's faces again. I don't know why I can't. Let me do my view, or at least I can see your names. And if you all want to, you don't have to, but if you'd like to come off of your camera, you're more than welcome to. Don't feel like you have to. I can just stare at your names, which is good, but of course, faces are always better. This was, like I said, I went through it in about a half hour or so. Hopefully, it wasn't too quick, but is there anybody on who has had a patient in their chair and maybe wasn't sure how to approach this or how to approach a male patient? I get that one a lot when I train. Show your face. I love you. Can't you guys see? Why can't you see my face? This is what I don't understand. Let me
We,
come back on. There we go. Can you see it now, Trace? Hold on.
yep, we can see your face.
All right. There you go.
We just want to see everybody else's face. And
Yeah, if you guys want to, as long as you go ahead. What are you gonna
Sarah
say?
Fraser is the physician that I told you about that gave the most amazing talk in Halifax. Not a surgeon, but does
Oh, thank you.
reaffirming. So you were amazing, Sarah.
Oh,
So
Is Sarah here?
thanks.
yeah,
Oh,
Yeah, I'm
perfect.
here. Thank you.
I'm excited because I wanted, so thank you for clarifying that to Trace. Sarah, we just had a conversation, Trace and I, about you right before we got
Nice.
on.
Yeah, I saw a few minutes late because I was in another meeting. Believe it or not, it's 9:30 in Nova Scotia here now.
That's
Um,
great. And you go ahead.
no, you go. It's okay.
Oh no, it's nice to have you. I know it's long, and I was very happy that you came on because honestly, we were just briefly talking in my brain. I went right to surgery, so I didn't mean to misstate your credentials.
Oh, no, that's okay. I'm a family doctor and I opened a gender affirming care clinic. So I'm doing that full time. So it's mostly hormones and surgery referrals, but I took training with previously, but then refreshed earlier this year with Tracy. And so I've been doing neuromodulators and filler mostly for trans folks within my practice,
Yeah.
just kind of starting out. And so I really liked this presentation. I was wondering if you could talk a little bit more about the nose and maybe like a little details about, yeah, precisely where you inject for that. I'm kind of intimidated by, well,
Yeah.
definitely with filler right now, but also with even neuromodulators around the nose. So yeah.
Yeah, I can. What I'll do is maybe I'll bring the presentation back up.
Yeah.
It doesn't. So what we're doing is called the depressor septi muscle of the nose. Normally, I personally injected it most of the time. If someone looked at me and their nose tip was down a bit, and when they talk, it would keep going up and down. And I used to get great results. When I inject there with neurotoxin to lift it lifts it. Some people it does lift a little bit much, but it just depends on the strength of that muscle. So I'll show that. For filler, the thing with filler, I'm very cautious in many areas. So I'm glad that you're taking caution because of certain vasculature, and there are some higher risk areas. Underneath, people will sometimes come under, put a little filler here. You just have to be careful not to change the convexing concavities naturally that occur under there. And there's also, if you come up underneath, we have the columnellar arteries that come up, and I mean the filtral arteries, and they come up to columnellar, which is in the tip. So it is a little bit, to me, it increases a little bit of the risk, but the nose is very nice. It's very vascular. But let me show you where you would kind of inject where that muscle. The depressor septimizal comes from this underneath of here, right between the ala, down to right, basically right underneath the upper lip, and it kind of contracts. When it contracts, it does this. So it's a depressor. And that's why neurotoxin kind of works to relax the depressor activity. Let me see if I can do this. And you guys, so Sarah, I'm going to also use you as my voice of if you can see. So I'm going to bring my presentation
Sure.
back up, and I'll point and then make sure you can see what I'm doing. I'm so happy you're on, and gender affirming care is amazing. I'm so happy you're doing that, and I may ask you a couple questions to help
Yeah,
educate the rest of us if I could.
sure. Yeah, I can see
Um,
the
so
slides.
yes, and then of course here I am. Darn it. As I move my slide when we're talking, right? Isn't that great? Kev, I don't want to do that. Let me do this. Let me go from the current slide. I'm going to do something. Can you see my pointer? We're going to
Yes.
show you two. I'm going to show you here. We'd inject there, but I'm going to show
Yeah.
you another here in this patient
Yeah.
right there. Right at
Okay.
the base. I don't know why it does that. Right at the base. It's not on the spine. It's right on the base. Right there is where you would inject right underneath of it
Okay.
and right there. And you have to here. The thing is, we have the L sands levator aliquot nasi. Oh my God, L sands. Isn't that terrible? Levator superioris aliquot nasi coming down here for lip elevation. Then it comes in here.
Mm-hmm.
So we want to stay away from that. We have orbicularis, which is going to be a little bit more superficial to that muscle there.
Mm-hmm.
So just some ideas. You want to stay away from certain
Yeah.
muscles that are there.
Okay.
So anyway, so I wanted to kind of show you that.
Thank you. Yeah.
Yep, so that's the levator superioris aliquot nasi, and we just call it the L sand that comes down. Many people think it drops straight down here, but it doesn't. It actually comes down and comes in a little bit. So does that help with that?
Yeah,
And then
thank you.
people will put filler here, and then sometimes depending, they may do, depending on what you're trying to achieve, sometimes they'll do tips and noses. This is just a highly vascular, very variant anatomically. And it also, there's no such thing to me as superficial and deep. I've seen these vessels be right under the skin. In fact, I was doing a cadaveric workshop with one of my colleagues, and we just for kicks, we inject it here. Most people say that the dorsal nasal artery will come down on either side, that it's not central, but it was central, and we inject it and we cut it down, and guess what we did? We cannulated the vessel.
Mm.
So there's no safe, I don't care what people say, safe technique. There isn't because you don't have X-ray vision as to what the anatomy looks like unless you maybe have ultrasound or something. So I love your caution, and it's just about education. Let me stop sharing. And I think I did. Did I stop sharing?
Yeah. Mm.
All right, thank you. Well, that was great. So I do have a question. So before I continue with for Sarah, so is there any for us if we're dealing with transgender, are there any maybe verbiage, sensitivity things that you found to exist, or is this all made up, or how do you feel? And when you got into this, were
Yeah.
you concerned about this, and how did you alleviate those concerns?
Yeah, I think one thing would be when it comes to language, you can ask people what their pronouns are
Okay.
and then kind of highlight that in your chart. So whether people might use she or he or they or kind of a combination sometimes.
Okay.
And so, and then if you like are, you can introduce yourself using your pronouns, and that can kind of make people feel more comfortable as well. And yeah, even like the language on the intake forms. So instead of just having like male, female, and kind of leaving it at that, you because that's kind of referring to sex, but people gender is how someone, feels inside. So you could just say gender and leave it blank. Or if you need to collect like the legal sex for, insurance or demographic reasons, you could kind of say have sex, but then have a gender category. You could have non-binary, so someone who doesn't identify as one gender or the other. So kind of even the initial intake forms are something that you can kind of use to create inclusivity, like from off the bat. And just like you said, just because someone is, presenting as male, they might not have masculinizing goals. So yeah, just kind of stripping assumptions away can be a good thing.
Thank you for helping because I really think I know I'm not always up to date with everything. And like yourself, I'll ask people, but I think it's always good just to be a little bit more sensitive. And it really helps me, I think, with everything, even when I educate. So I appreciate you taking time to explain.
Yeah.
And you bring up an interesting point, non-binary, right? So what does that mean? It means they really, I believe, you can correct me, don't really relate to either sex. They're kind of, it's just
Yeah.
non-binary. It's so these,
Yeah.
imagine if they're in your chair. So here we are,
Yeah.
non-binary. How do we make someone non-binary? So like, the question is, well, let's talk about the features you like, because they may say, I'm just here because this bothers me. So say it was cheeks. And at that point, I'll say, okay, well, non-binary is, sometimes it may shift, right, to saying I want to be more feminine or masculine. Luckily, what we're doing, it's not permanent, which is good because things do change. However, I think the thing is, what type of, if we're doing cheeks, do you want your cheeks to be more masculine, more feminine? And it's hard to be neutral total with it, but or do you want both? We could change maybe the projection here. So it's using but it's all about the foundational learnings about what is presented more masculine and feminine. Now, over time, maybe this will change. I don't know. Who knows, right? Things change, but it's good that's why it's important to understand the concepts of male, female, what typically presents that way, because I think then we can talk to our patients and really have an open communication to see which way they
Mhm.
want to go. And once again, I think it's important if someone is, they say non-binary, saying, in the future, if you start relating to one, or the other, things can be done to adjust because these are not permanent. We're not using permanent fillers. And even if we do our neurotoxins, because now some things we have to be cautious of, especially with neurotoxin. If we start atrophying muscle, will that come back? You can chew gum and try to bring stuff back. I don't know. I've never done the study, see how much we can get back, but who knows? But I'm really glad. And you bring up, this is really why I want this presentation. When I first start presenting on this, it's really just black and white, male, female, whatever. But in today's society, it's very different. Things are accepted, things are spoken about that we never thought of. But going back to the point you mentioned, it's about your patient in your chair and communicating openly. And to me, ask questions, right? If you're not familiar, if you feel uncomfortable, say, look, I just don't want to do anything to insult you. Here's what I know. Please educate me so I can be more open and I don't make you feel uncomfortable. Because everybody just doesn't matter who you are, you want a safe environment, right? And that's kind of what you're creating. So thank you. Any other, I really